for questions. That's okay. Absolutely fine. So what I was going to do was basically just to very briefly, for those of you that don't know, just to say what we do. So CQC, our purpose is to make sure health and social care services provide safe, effective, compassionate, high quality care, and we are also an organisation which encourages services to improve. And I think a lot of people have not seen CQC as an organ for quality improvement, but certainly that is the direction of travel, that whilst we put the bar at a certain level, we want organisations to ensure that they reach that level and to improve. Our role is, as you maybe know, is to monitor, inspect and regulate services so they meet fundamental standards of quality and safety, and then we publish and rate, and ratings are obviously very important both to providers and also to the populations that they serve. Just a brief outline of structure. So at the top is a board, including the Chief Inspector of Hospitals, who is Ted Baker. Beneath him are 4 Deputy Chief Inspectors, and then below them is a tier of professional advisors. Myself for surgery, we've just appointed a new advisor for medicine, 1 for maternity, several for mental health. I think there's sort of 8 of us in total, and then we will sort of develop the themes and the standards that the inspection teams will then inspect against. We tend to look at our inspections against 5 domains. These are well-led, safe, effective, caring and responsive, and we tend to look at well-led, caring and safe as fairly generic. So safe, caring is the standards are the same no matter which provider you're in, and pretty much the same for well-led, although there will be some slight speciality specific aspects. Effective and responsive, as I'll show you shortly, are much more speciality specific, and this is much more where we look at clinical outcomes, where audits come in. So these 2 domains are the ones that I tend to concentrate on. We've had a complete round of inspections that was finished about 2019, so every provider in the country has now been inspected. It's a massive undertaking, as I'm sure many of you will know. It's hugely time consuming, it's labour intensive, it's very, very expensive. And also we tend to inspect what we call core services. So general surgery is a core service, although there are 11 subspecialities, but there is no actual, or there was no actual subspeciality focus. So we would inspect, I work in Liverpool, so for example, we would inspect the Royal Liverpool Hospital and we would look at their generality of surgery, but we would probably have not much idea of how breast surgery was doing as a subspeciality, or ENT was doing. We would just look at surgery overall, and that meant that you could possibly have some poorly performing services within an organisation, which we would not always identify. COVID for us has been a challenge, as it has obviously for everybody, but out of all challenges come opportunities, and one of the good things that for the way that I wanted CQC to move was that, of course, you couldn't undertake face-to-face inspections, only really if there were major safety concerns, which meant that we had to get smarter. We had to use the intelligence that we had, and we had to look at ways of gathering new intelligence. We had to use what we call enhanced monitoring. So we would have to monitor providers rather than keep going in and inspecting them. And there would have to be more collaboration between regulators, because with resources limited and an inability to go into trusts, we had to find a way whereby we weren't all asking the same questions and putting providers under pressure. The question, of course, came that with all the surgical subspecialities and even more in medicine, where did we actually focus? So in terms of collaboration, we were already collaborating pretty well with HQIP, but we signed a memorandum of understanding with GIRFT. We've been working closely with the Hospital Special Investigation Bureau, with NHS Resolution, with the Royal Colleges, and also with some accreditation schemes. So the plan is basically to screen, and if we identify concerns, then we can go on and do a deep dive. If we don't have any concerns, then we can continue to monitor. And if the deep dive identifies concerns, then we can go in and do a focused inspection. And we hope that that inspection will be on the subspeciality and not on the whole of surgery. Of course, we may do the deep dive and actually find that there are no concerns, and then we can continue to monitor. The deep dive will use more detailed GIRFT data, audit data, data from registry, external reviews, the IRMs that take place, NCAS reviews, NHSR, HSIB. I noticed somebody's put on the chat, is it true that PI has become obsolete? The answer to that is basically yes. Accreditation schemes such as JAG and anaesthetic accreditation, GMC trainer and trainee surveys, particularly the trainee survey, are incredibly useful at identifying problems. Friends and family tests, we already get most of this data already, but it's now using it as a way of enhanced monitoring. And then other stuff that we get from other data we get from trusts, never events, DICE reports. We get quite a lot of whistleblower reports. We have relationship owners, so every provider has a CQC relationship owner, and obviously they will have a lot of local knowledge. We will have inspected them all now previously, and we'll have some mortality outlier data. So what I want to do now is to give you a run through of basically how this will work in progress. And the most of the data that we will get from GIRFT will be through Model Hospital. So what I've done here is I've taken the GIRFT, what we call key clinical or sentinel clinical metrics for orthopedics. And one of the very key metrics for all subspecialties, including my own, is emergency readmissions. So patients go home and they come back within a certain time period, usually due to the development of a complication. And for orthopedics, they've put in quality standards as opposed to having 2 to 3 standard deviation alert and alarm outliers. So if we look at the GIRFT key clinical metrics and we look at 30-day readmissions, then you get this run chart and you can see it split into quartiles. And what I did was to look at who performs worst. And unfortunately, if any of you are having your hips done in the near future, this turned out to be St George's. So what we saw was that at St George's, there is a far higher instance of readmission within 30 days of primary hip replacement. So that's, in a way, that's just one of our little screening tests. So was it just hips, or were there other areas of orthopedics which were a problem as well? So let's look at the deeper dive into the hip metrics at St George's, and we can see that there are several metrics here which actually have come out red, and where they come out above, or outliers above, both peer and national median values. So they don't seem to be doing very well on hips. So was that just a one-off, or is there a problem with lower limb surgery in general? This is knee replacement, and you can see that in fact their 30-day readmission after total knee replacement is also almost the worst in the country. So That's hip and knee. What about trauma? Well, this is 30-day readmissions after fractured neck of femur. And you can see that, again, they are there within the bottom quartile. But we know that, so it looks there as if there might be a problem with lower limb surgery at that provider. But we know that there are 11 surgical subspecialities. So are there problems? Is it a problem with surgery in general, or is it a problem just with one or two areas? So let's look at another surgical subspeciality, and this is cardiac surgery. And this is 30-day readmissions after aortic valve surgery. And you can see that, again, they perform very poorly. And there's a chart which I haven't put in here, but if you look at returns after coronary artery bypass graft, it's the same sort of thing. So we found two areas where the provision of that service appears to be substandard. But if you look at elective colonic surgery, it seems to be fine. And this was, if we'd have gone and just looked at surgery in general previously, we'd have probably seen this and thought, oh, well, actually, they're performing okay. But you can see how we would previously have had the potential to miss areas of poor performance if we didn't look at this on a subspeciality basis. And this is their MBOCA audit at 2 years, and you can see they are bang in the middle of the funnel plot, although there are obviously some outliers who we may be more interested in. And if we look at their NELA audit, which is, as you know, National Emergency Laparotomy Audit, you can see that basically they are pretty much green. There's one area here where about preoperative assessments, which is red, but pretty much they're green throughout, and that's probably acceptable. And if we look at their genital urinary complications after radical prostatectomy, this is taken from National Prostate Cancer Audit, you can see that once again they are bang within the middle of the normal range. So what I've sort of tried to demonstrate here is that there are different performing subspecialities within the same organisation, and if we're going to be a smart regulator, then we need to identify areas of poor performance rather than just look at it overall and say, well, actually, their overall performance is okay, because Georgia scored good in their last ratings. Surgery was rated as good, but you can see that there are areas within that good where performance is poor. If we look at the National Prostate Cancer Audit, you can see that this provider here is an alarm level outlier. And if we look at that, we find that that alarm level outlier is actually Bradford. So again, we can ask the same questions about Bradford. Is it just urology, or is it that there is a more widespread problem? And that's their readmissions within 90 days after radical prostatectomy. And this is returned for a further procedure within 1 year after cystectomy, which is where after bladder excision. And you can see that they are right at the outer end of the quartile, of the lowest quartile. So it looks as if urology there may be a problem. And if we look at 30-day readmissions after nephrectomy, after removal of kidney, then we can see, again, they're in the bottom quartile. But if we look at their NELA data for their surgical emergencies, general surgical emergencies, you can see they're pretty much, they're okay. And if you look at, sorry, I'll just go back. So you can see they're pretty much okay, meaning that this problem seems to be limited to urology. And we've looked at other subspecialities, and it seems to be just urology. So our inspectors would go back in and start a conversation. It doesn't mean that they have a problem. It means that there's a conversation to be had whereby there may be a reason, there may be, you know, a reason as to why they had a poor outcome that year. It may have been that the other 3 or 4 years before their outcomes have been okay. So it's a start of a conversation. It doesn't mean that they're going to to go and have inspectors all over them. It's just the start of a conversation to say, have you looked at this, and is there something that we need to do about it? Now, for the last few years, CQC, myself, and particularly one of our previous analysts, Keiko Tomo, have worked very closely with HQIP on their national outliers. And this came about through a conversation where there were concerns from Danny and his team at HQIP that all of this work was being done on national audits. They were going back to the trusts and saying you're an alert or an alarm, and the trusts were not really putting in much of an action plan and weren't really taking it all too seriously. So what now happens is, and we were asked if we could help them with that. So what now happens is that when an alert and alarm is identified, a letter goes to the provider from HQIP and from CQC asking the trust to put in place an action plan. That action plan is put in place, the suitability action plan is assessed, and assuming that it's okay, then time is given for that to be implemented, and obviously it is then re-audited. But with us working together, we have found that providers are obviously much more willing to engage, and the word has got round, and now really CQC doesn't have to do an awful lot, because when HQIP write to providers, they tend to find that they engage with their action plans and with their reassessments. So I just wanted to show you one slide here of just to show you how working together and how audit can actually improve the quality of clinical care. So this is the MBOCA audit, and I know it's very busy, but I just want you to focus on one line. And what this line here shows is the provision of laparoscopic colorectal surgery. So keyhole surgery for bowel cancer has certain advantages in that obviously you're accessing the abdominal cavity through small holes. The patient hasn't got a big laparotomy incision to get over. Their outcome is quicker. There's no their cancer outcomes are the same, and their return to normal activity and recovery is very in hospital stay. All of those metrics are very much quicker. But if you look at this provider here, then what you can see is that they don't provide any laparoscopic colorectal surgery whatsoever, whereas neighbouring providers can provide up to 60%, which means that patients presenting to this trust, which at that time was Barnsley, are immediately disadvantaged because they don't have any access to laparoscopic colorectal surgery. So using the MBOCA audit, we met with their chief executive. We pointed this out to them and to their commissioners. And two laparoscopic colorectal surgeons were appointed. And this trust now provides laparoscopic colorectal surgery for patients where it's deemed suitable. So you can see how all of the work that is done that goes into this audit can actually be used to improve the quality of care, providing that the data is properly analysed and presented to the providers. So before you ask me some questions, I wanted to ask you some, maybe to think about, and that is, should we be making more use of quality standards rather than relying upon alarm and alert outliers? And I say that because if it's agreed that the mortality for colorectal cancer surgery, the operative mortality is 2%, and everybody's 1.9%, and basically there are no outliers. But if you draw it as a Gaussian curve and you have 2 SD and 3 SDs, then obviously you do have outliers. So I wonder whether we should be moving much more towards quality standards and away from this. Be interested in your views. And the other thing is that certainly from a CQC perspective, if providers don't put patients into the audits, then how can we make sense of them? And I would throw out as a number that if accrual is less than 80%, then that provider is an outlier and should be treated as such. So interested in your views on that. And that's me done. So thank you.
Okay, thank you very much. That was very comprehensive overview there. Seem to have an echo on me. I don't know whether it's because I'm sharing my screen or not. Do you want me to take control?
Yes, you can take it off now, unless anybody wants to see the slides again. Thank you.
I can't see the 3 questions you've asked us now, of course, but
yeah.
I mean, just from my personal point of view, before we offer it out, I mean, NQI kind of been very supportive of using national clinical audit to drive improvement for a long while, and it's great now that it's been integrated into the CQC inspection regime like it has, albeit with a caveat that the time the data is reported on and then there's benchmarking have been produced, it's a little bit out of date, so it's somewhat quite significantly out of date in the eyes of the clinicians sometimes. So I think that's just always a caveat to that in terms of, you know, is there a risk today or tomorrow, not 2 years ago sort of thing. And obviously you'll have had conversations with HQIP around how you negate that sort of thing in terms of getting assurance from the provider if they are an outlier, etc. But the way I've always seen it is that if you have a top 20% and a bottom 20%, you're always going to have a bottom 20%. And if you move to quality standards, that would reduce that, because if you set a target where this is where we expect providers to be, then there doesn't always have to be a bottom 20%, which you have by the nature of the way you analyse the data. So
yeah, I noticed also the National Vascular Audit now do that. They have quality standards, and as long as people are within those quality standards, then obviously they don't have outliers. I think the thing that you've just said about real-time data is hugely important, and for those of you that were engaged with the recent HQIP methodology, they had 4 meetings to look at their methodology going forward. This was very much a topic across the whole. Across all of the meetings, because we want data that, as you say, is as up to date as possible, and having, you know, data from 2018 is not much use to what's sometimes happening in 2021. So how we get more real-time data is obviously very important.
Okay, thank you. So any other questions or responses to Mike's questions to us?
Carl, if I may quickly, sorry, grabbing in before Linda, just very quickly, it's just an observation. When CQC visited one of the us, and it was a good experience, very in-depth discussion and talking through. But that was one of the observations of, you know, where you made the point that HQIP was saying, you know, here are the national audits, the actions aren't necessarily undertaken within the organisations, comes back to that triangulation of sometimes our executive officers, our clinical teams might see the data as being too old, and sometimes there's a danger of it being dismissed as it being too old. You see the latest round of the national audit being data on 2018. We all know that will be because there's outcome data there and there's very valuable information that we can gain. So it's about how we change the culture within the organizations to recognize that until we have real-time data for everything, there will always be a lag time, and it doesn't stop the validity for that information. So if a pathway has naturally changed because of reconfiguration, different ways of treating, that's it's about how you look at the action plans and recognize how there are those changes, but what other things stay exactly the same and need an action plan that is actually smart. So we're looking at an action plan that is not just, you know, I'm going to do a presentation to my governance group. This is about ownership from the executive team and having good reporting and highlight and exception reports as well. So I think there's a big thing about training and education in organizations, awareness of the validity of data, and actually doing some change, some real adaptive changes within that clinical setting. Apologies, that was a lot at once.
I think the important thing as well is to get clinical buy-in. It's all very well having the executive team and everything, but you have to have the clinicians bought into this. They have to be able to know. You should know, as a colorectal surgeon, I know my data. And, you know, if it wasn't very good last year, I'm very aware of where it's going this year, sort of thing. So you have to know your data, and I think one of the ways that the providers, the medical director, can ensure that clinicians know their data is to make it part of their appraisal, which they don't do at the moment. So your outcome data should be part of your appraisal, and if they did that, then the clinicians would know their data. The other thing to say is that this is about starting a conversation. Yeah, it isn't about this is the only way it can be, and it's about starting a conversation. So, if you look at anybody's data over 10 years, you may find that one year that data wasn't very, their outcomes weren't very good. That could be just because that year they took on a whole load of complex cases, which they can show. And the next year they didn't, somebody else did, and the data was better. So it is just about having a conversation. But if you're not aware of your data, then there's no conversation to have.
Yeah, so it's having a grip of your data and knowing exactly, so that when you do get a letter from CQC as an outlier, you know you are, and you can say exactly why that is. So, because that's happened for my trust a few times. Okay, so Linda, next question, please.
Yeah, thank you. It's just in response to your question to us, Mike. My name's Linda. I work in a mental health trust, but I also work with the Royal College of Psychiatry, and I sit on the national steering group for the National Clinical Audit Psychosis. And I'm all for team threshold or team targets instead of using 2 and 3 standard deviations. And the reason for that is on the NCAP audit, one of the standards is on physical health monitoring. So it's the screening and then the interventions against physical health. And over the last few years, my trust has been, like most of the trusts in the Northwest, an outlier. However, on the last 2 cycles, we saw a massive improvement from a single figure up to the high 50s, which is a fantastic improvement. But the rest of the country also saw massive improvements, and we were still an outlier. It's disheartening to the organisation, disheartening to the clinicians, and very difficult to think of more smart actions that we can do, because we're already seeing massive improvements. So we have had those discussions with the college on the steering group, and we are considering changing, instead of 2 and 3 standard deviations, going and deciding on a threshold. So I'm for team thresholds.
Excellent. Yes, I think so with us as well, and with a lot of the cancer audits and clinical audit. You reach a point whereby you probably can't get it much better. If you look at the type of patients that get operated on, if you're operating with a 2% mortality, you're probably not going to get it very much better than that. But yet you're still going to be an outlier, which is because of the stats and not because of anything else. So yeah, I'm with you, Linda. Yeah.
Thank you. Thanks very much. Thank you.
Okay, next question from Sarah Byrne, please.
Hi, yes, I'm Sarah. I'm the chair of the Mersey Quality Improvement Clinical Audit Network. I mean, I echo what the other guys have said, but I think also to come back to the issue that you mentioned about case ascertainment and participation rates, I'm really support having high targets for case ascertainment, because if you don't have your patient population captured, then the rest of the measures, your performance doesn't count as far as I'm concerned. It's the data's skewed. And I think the other thing that I would say is that there's a definite, around the access to real-time data. There's a big push in our organisation to review the national portals at a local level on an almost monthly basis. We definitely found with NELA, for example, going years back, there were lots of problems with concerns about the data being so out of date, and as people have sort of alluded to already, almost like just being dismissed because it was so out of date. And since NELA have started producing quarterly reports and quarterly updates, it just makes the whole thing far more meaningful and gives us a little bit more it helps with that engaging with clinicians, because they see the data as being valid, and they take it on board that where there are issues or things that need addressing. But one thing that I have experienced in the past, and I don't know if that's been addressed across the board yet, is that a lot of the consultant level data is only available to consultants, or when there's an issue, it gets flagged up to the medical director. And it's almost like, you know, at a trust level, if we can't access that consultant level data, how do we look at that to try and, you know, put something in place prior to it getting to medical director level? And I think that's been the case with some of the registries in the past, particularly.
Yeah, and BAUS particularly. Yeah, definitely.
Yeah. Thank you.
Excellent, thank you, Sarah. So Diane, did you have your hand up? I don't know, it's gone down now. Perhaps your question has been asked now, but yeah. So are there any further questions? As I say, I mean, it's confirmation now that the process is changing, and it's good to see that you're using intelligence to, because it must be very expensive, as you said. You know, I've never seen any figures in terms of it all, but
well, I think you're looking at your thing. Are you at University College London?
University Hospital of Leicester.
Oh, Leicester, right. I was going to say because I think the inspection of UCL, because obviously we had to have inspectors in central London hotels, cost something like £500,000. So it's phenomenally expensive, and you can very easily miss things because, as I think, you know, you can see, some of the subspecialities in surgery will be fine, whereas others within the same organisation won't be. So, and also when we inspect, we try to take, obviously we have our inspection teams who are not always clinical, and we try to support the inspection teams with a clinical advisor. Well, what tends to happen is, of course, is that you find a problem in orthopedics and your clinical advisor is your urologist, who says, well, hang on a minute, I haven't done any orthopedics since I was a student. So this way makes us, as a regulator, much more effective, because we can actually then make sure that we staff any subspeciality inspections with the right clinicians.
Yeah, no, it's all teamwork, and it's all about joined up analysis and also effective action plans, and that's all about what we do, isn't it? Quality improvement. So and again, it's good to hear that the sound bites from CQC is that previously through their inspections, I certainly got the feeling that clinical audit, they didn't want to come and speak to me, or they didn't want to see clinical audit data, but now over the last recent years it's so much more integrated. So that's great to see, because it is a rich source of information. Okay, so Diane, has you got your hand back up now?
Yeah,
the time.
Yeah, I agree with you, Carl. You know, we don't get much engagement with CQC when they come into the inspections, and I just don't think, you know, we're being told that we need to make sure our clinical audit data is up to scratch for when CQC come in, but nobody ever looks at it, and it's not taken into account. It wasn't part of your presentation then, Mike. It was all about the national audits and that. So what do we do about the local audits? Are they still part of the CQC inspections?
Yeah, I mean, hopefully, as this, I'm doing this as a pilot at the moment. And again, I think that this is where the conversation starts, because if we identify a problem with, I don't know where you work, Diane, but if we find a problem with your organisation at a national level, then we can come into you at a local level and say, well, this is what we found. And you go, well, thank you very much. Here is our local audit, which has already addressed this problem, and here are the outcomes, and here's the reasoning behind it. And it's very interesting, you know, when we look at our mortality outliers, we find that when we go to an outstanding or good trust, that's the CQC rated outstanding or good trust, and we say your mortality outliers for, I use colorectal again, for colorectal cancer are high, they say, we know, we already know, we've already looked at it, here's the audit that we've done, here are the reasons, etc., etc. When we go to a trust that's inadequate or requires improvement, then quite often what we get is, really? Oh, we better have a look then, hadn't we? So it is all about that management governance ethos and ability to know what's going on within your organization. So those local audits are very important, because they will quality assure you, and then you can quality assure us. Yeah.
Yeah, definitely.
Thank you.
Good question. Thank you, Diane. Okay, so any other questions once we've got this opportunity? Okay, there's been one or two comments in the chat as well. Is there anything from your perspective, Caroline, about the future liaisons with? I know recently I've been asked to look at some national clinical audit on model hospital, because I know you're testing out that about hosting everything there as well, or whatever, so which would be a good thing.
And we're looking at data through model hospital now, so we're using that rather than keeping on going to trusts and going to GIRFT and going to everybody else. We're actually trying to get everything we can from model hospital, because the whole idea is that, and this was came up in the Patterson report, was that the regulators aren't joined up, and by all using the same data source, then hopefully the thinking and approach will be much more joined up. And also we won't keep pestering trusts, asking them for the same information time and time again.
Yeah, great.
But I think, sorry to interrupt you, Caroline, I think the relationship with HQIP and CQC seems to be working very well.
Yeah, I was going to say the same thing. Good, with good regular contact, and sharing data is really important to us.
Mm.
Yeah. So in terms of the moving from 2 and 3 quartiles to actually quality standards, that's probably what, 2 years down the line, is it? Or because we can't suddenly implement that to the national benchmarking program overnight, can we, sort of thing? So I suppose that is a aspirational aim, isn't it, I suppose?
Yeah, I mean, there are some audits like the vascular audit that I think have already done it, but it's interesting. I brought this up at the last MBOCA meeting that we support their audit, and you know, they then have to go away and consider what those quality standards should be. And of course, then what you find is that somebody on their council suddenly finds that they're outside of that quality standard, so they want to actually change it, and it's very difficult to get agreement. But I think that this has to be seen as the way forward, and we have to start putting pressure on the audit leads to start looking at this.
Yeah, great. Is that another question, Diane, you'd got?
It is, yeah. I just wanted to know, you know, the insight report that we get in a paper version or every month from CQC.
Yeah.
Is there any talks about that going digital at all? Because that would make life so much easier.
Right. Okay. Well, I'll speak to our intelligence people. I'm with them next week, and we'll ask them. But I believe that insight is changing anyway, as we go over to become a smarter, hopefully more sort of intelligence-based regulator. I believe that insight is going to change. But I'll ask them about whether insight. I'll leave myself a note. Becoming digital. I'm surprised that it isn't, in all honesty. But I'll ask them and come back to you.
Thank you.
And it was RIP to the PIR.
Well, yeah,
I think,
you know, a lot of that is there's so much of it now is changing. A lot of it is redundant, it's repetitive, and it's a massive undertaking for providers. And again, if we have much more real-time data, then why do we need it? Because if that data is coming into CQC, then we should have most of that data almost real time.
Brilliant. Okay, well, thanks ever so much for your time. It's been a really good presentation.
Thank you very much for inviting me, and I'll look forward to seeing those who are on the Anchor Pop meeting. I think we've got one. I think it's next week. So
Monday, yeah.
On Monday, yeah. Thanks very much.
Yeah.
Bye.
Thanks
Bye.
a lot.
Bye. Bye.
Cheers. Bye. Okay, so yeah, so I think that was very good. I'm glad we managed to get someone to present, because we've been talking about CQC for a while, haven't we? So I think that was very useful, and thank you for everyone's questions there. I don't think we've still got anybody from NHS England in the room, so that's why I allowed the questions to continue, because once we had the opportunity with Mike, so that's good. So is there any other actions we need to take beyond those discussions in terms of there's some suggestions there which we can minute, and thanks Rebecca, in terms of following that up with CQC and HQIP outside the meeting. But as I say, it's good to get an update on that, and certainly it sounds like they're thinking about trusts and all the work that we have to do, and trying to minimise the burden, as we always try and do with the national agenda. All right, okay, Emma and Sarah have got their hands up. Emma?
Do you think we'd be able to share that recording within our regional network meetings?
Yes, yeah. So what we'll do is we'll put it on our YouTube channel. That's unlisted, so you won't be able to find it if you're searching for it. But if you've got the link, you can just play it on any device. So let's work with the other forums we've done. So yes, I think that would be a good, nice 20-minute presentation, isn't it? At any future network meeting, if you wanted an update on CQC.
Yeah, I was gonna share it if the link's available. I was gonna share it at next week's meeting, which would be really good if that's okay. Thank you.
Yeah, provided Becca and Sarah can get a download, because I know last time it was problematic, but hopefully it's a bit shorter this time. Yeah, which reminds me, we probably need to stop the tape.